Okay, we're ready to get started with some question and answer period. Let me see here. This is a good opener. It says, will a typical lung cancer or lung carcinoid, and there's by typical you mean well differentiated neuroendocrine tumor, as shown it doesn't invade. It's a tumor only. Does it convert to atypical? And I'll look down the table to see if anybody wants to try it first. Otherwise, I would say no, that I have not seen the conversion. They come in as atypical by histology, and they may have lymph nodes associated with them, or they're typical and they're usually in the right bronchial stem. They predilect to that one area at the bifurcation, and they're removed. And for the most part, they're supposed to be cured. Now, the ENETS meeting in Portugal recently in Europe, the lung surgeons say there is no such thing as a benign lung carcinoid. That was their experience. Now, we haven't seen it. We follow the patients at least initially for 2 years, every 6 months with CT scans. And if you're lucky, the marker will be chromogranin A, and it's very helpful when it is positive. And but many of them don't even have a high chromogranin A, so the only way to really follow them is up until now, and the gallium-68 will be one way to continue to stage them maybe every year or two, is with CT scans every 6 months. And it should be noted, and I want to hear it, maybe Dr. Malloy knows, but they have programs now. There was that alarm regarding radiation and breast cancer, but the programs now are set for high-resolution CT scans where the programs use half the radiation dose. If I'm, is that correct?
Yeah.
So I think you can do that with some fearlessness, because I think you should keep an eye on them. And but typical is, in my experience, they come in typical, atypical, or small cell when you get them. And that obtains for neuroendocrine tumors below the diaphragm as well. I know Sloan Kettering has a progressiveness where they show a conversion later on to the more dedifferentiated, but I think we've seen some, as Dr. Del Posano alluded to, you can see a few dedifferentiated tumors lacking Triascan positivity within a nest of well-differentiated liver mets. You can see those, but it's how aggressive are you going to be for that one tumor versus the ones that respond to PRRT. In general, I haven't seen it. So I'd be grateful to hear a real medical oncologist tell me.
Well, I haven't seen it either. I have a number of patients with bronchial carcinoids that are typical, with that have been removed, and diagnostic studies indicate that they are slow-growing tumors, but I would never use the word benign, because they're not benign. They're still, as I mentioned right in the beginning, they're still malignant, they're still cancerous, but slow growing. And they have been removed, and I've not seen anything in the way of conversion at all. But they do need to be followed.
Yes.
And we still follow the patients diligently.
Mm-hmm. Same. Any other comments? Okay, here's a question here. Let's see. Sandostatin LAR, serotonin breakdown, either have effects on kidney. Actually, somatostatin was shown to decrease GFR, and for a while they were thinking of using it for proteinuria in diabetics, and it's in the native form. And octreotide can lower GFR by narrowing the vessels and in the kidney functioning kidney unit. But serotonin breakdown does not affect the kidney. In fact, there are only two places you break serotonin down. the most important normal place you break serotonin down to 5-HIA, 5-hydroxyindoleacetic acid, is at the kidney. So there's an enzyme there that breaks it down when it's cleared. So it's inert as far as I know and as far as tested, and it just goes out into the urine. The thing that gives you a higher 5-HIA is when the tumor goes into the liver, and now you're breaking down much more of the serotonin that's being made to 5-HIA, and that's what raises the 5-HIA level. And that's what I said in our experience. It takes a visible 5 to 10, maybe 10 to 15% liver tumor burden before you start seeing a significant rise in 5-HIA. And you have to be very careful and make sure it's HPLC 5-HIA, because they used to use an enzymatic test, and levels as high as 100 were completely benign in some patients when they use the different testing. But the good labs will use pressure chromatography to separate it. But it takes about a visible 10 to 15% liver tumor burden before you can really follow the 5-HIA. Second part of the question was, after having a cycle of PRRT treatments, will they ever have to be repeated? So that's a very good question, and what Dr. Del Passant did was show you single radionuclides. He showed you indium-111, he showed you yttrium by itself, 90, and lutetium. There's two centers now from Europe that independently stood up at a meeting, and Dr. Del Passant was there, that showed when you use 2 treatments of Y90, usually or 3, depending on that 2100 rad limit to the kidney, that you can go on and give lutetium, usually two treatments of lutetium, and the combination imparts longer what would it be, tumor-free progression by about 1.5 years, almost 2 years. 2 independent centers were within 1 month of showing, when they did both, 2 treatments of yttrium and 2 treatments of lutetium, that it extended the impact of the progression-free disease.
Another part of this question might be if we complete our, for instance, 4 treatments for lutetium, and here patient either goes to a stable disease or partial response, and there is no progression of the disease for a while, which based on, again, reports that we see in the literature is between 36 months to sometimes 6 years even. After that, if they start progressing, can we still give them PRRT? And the answer is yes, based on some of the reports that we've got. I know 2 reports from Erasmus that they give 2 more cycles of 200 millicurie
each,
about 7 years after the completion of first 4 cycles, when the patient starts showing some progression safely to the patients. And again, those 2 sort of booster treatments kept the patient in line and the tumor in line, and it didn't prevent the progression for several years.
Follow-up question?
No, it's I just know from the protocols in that Berkeley course that you can do multiple sessions, and the most that I know of is 10 treatments, not cycles, but 10 individual treatments using multiple versions.
Dr. Del Passant, if there was an equal playing field, and of course there isn't now, but if all 3 agents were available to us at this time, given the difference in, you just said we can use them sequentially.
Sure.
Given the different penetration of the rays, being a beta emitter or a gamma emitter, etc., what would be your preference in the sequence? Which agent would you use first or second?
Sure. I think it depends. One of my main criteria is going to be, if we have all 3 available, is going to be the size of the tumor. If the tumors are typically, bulkier tumor, larger tumor, probably larger than 5-6 centimeter, even some of the lesions, I probably try yttrium initially. And if the lesions are, below 3 centimeter, I probably still want to go with indium. And between 3 to 5-6 centimeter, go with lutetium. And the combination of these, of course, can be done as well. But I think the major sort of physical differences between these agents, as I showed, is the tissue penetration.
So if you started with a larger tumor and you started with yttrium and it shrunk, would you use indium?
Probably.
The size
Yes.
shrunk enough to use indium?
If it shrunk further, then you can probably do lutetium and then go to indium as well. As an adjuvant therapy, when you have done surgery, majority of the tumor is out. There are some question about borders of the tumor, resection. There are maybe some cells left. I definitely prefer indium. I think that has the least side effects, and for that kind of sort of a microscopic areas of the residual tumor, I think indium is ideal.
Yeah, and I would just follow up. There's something very clever on Dr. Del Passant's slide when he showed the differences, and it was a subtle one, but it's valid. The bismuth 213 is now being talked about in Heidelberg. We both heard that, and they're reserving that for yttrium and lutetium failures. And then they're using the bismuth, because it's just as Dr. Del Passant showed. In order for bismuth to work, the complex has to go into the cell and close to the nucleus to kill with alpha energy. But indium-111, the energy Dr. Del Passant has used effectively, is called Auger, A-U-G-E-R, and that energy also is very powerful up close to the nucleus. So I could see yttrium and lutetium in the U.S., and then maybe indium-111 as a third stage if there was some breakthrough. It makes a great deal of sense, and the range that the doctor was talking about is just what Dr. Del Passant. Y90 has a slightly longer, harder energy. Lutetium has a slightly softer energy like I-131, and then the Auger or alpha energy would be the shorter distance. If I can go on, I'll address the middle one first, because this was addressed of the three-part question. Is Prrt done as a last resort when other treatments don't work? And the answer is, right now we're doing registration trials, which by definition requires progression of metastatic disease. Everything is being studied, as Dr. Gerstein alluded to, and Dr. Labate. It's all being done because you have progressive disease that these folks are being studied. Once it's FDA approved, we will answer that question. And is there a cure possible? It's just what Dr. Del Passant alluded to, and I think we did too, and that is you're going to have aggressive surgery once, and then you're going to follow it up with probably PRRT. That's how it's going to be done. And all the other boxes that I show will be effective options as you need them if there's recurrence. That's how it's going to be done. This isn't a last resort thing. All you have to do is put the number of months that you've heard about today under each of those boxes and add them all up. And that's about how many great years of survival you have, including surgery right at the very top. Will give you, and the studies of Dr. Howe, Dr. Labate, clearly show that primary resection and resection even with metastasis extends survival, flat out extends survival. And just add those years up and add the Y90 spheres, which are 3 to 5 years, and you add up PRRT, you're almost out to 15 years with 3 boxes. That's what it's about. It's taking the right option at the right time. And that's where the managers come in. Like they have at Montefiore, like we have, like LSU has, and Wolin. And you should feel very hopeful with all of that. Do you continue Sandal statin analogs after PRRT? I'm a believer in that for life, because it makes no sense if you do an Octrea scan and you show that you have the receptors, and it's been shown very clearly in the PROMID studies that octreotide is a as they say, a modest anti-proliferative agent. That means it's therapeutic. You've gone from the original indication of symptomatic improvement to therapeutic, anti-proliferative. And if after you have PRRT, you have a quality of receptor that's still there, which means it will respond to octreotide acetate.
Just one comment, Dr.
Sure.
Luis, if I may. We have some restrictions when we are doing PRRT, as Sandostatin is a cold version, is a cold analog of octreotide that we also use as a vector to take the radioactive material. So we require that between 4 to 6 weeks be the distance between the time that you receive the Sandostatin LAR, I'm talking about the long-acting one, before the time that we can actually do the treatment PRRT, because we don't want to have any competition between the cold Sandostatin versus the one that radio-labeled one that we inject. For the short-acting is different. Short-acting, our patients can continue having short-acting if they need it, even up to 48 hours prior to the therapy, and they stop it. Yeah. Before the diagnostic test, also we like them to stop for the cold one 48 hours before, so we can have a good diagnostic octreotide scan. In terms of continuation of Sandostatin, of course, there are some reports now that suggest that it has anti-proliferative effect. But if it is, the goal was mainly to control the symptoms. We have seen many patients after PRRT, actually, the symptoms are relieved and they have either decreased or totally stopped the doses of Sandostatin.
And in fact, if you recall, the Journal of Clinical Oncology just published the Basel was 1,000 patients. Imhoff was the first author, and they looked at morphologic response, clinical response, and each one of those categories, if there was a response, boded very well for durability of the treatment. And Dr. Del Poison's point's very well taken. The long-acting repeatable has to be stopped 5 to 6 weeks prior, and if you're having symptoms, you can use the short-acting sub-Q, and with a half-life of 2 hours, I usually say 24 hours, but 48 hours is sure to clear all of the short-acting out before you have the competition. One other question that this person asked, if patient has metastatic disease and unknown primary, does debulking surgery need to be done before PRRT? And I'd have Dr. Labate make a comment on that first.
So if you have metastatic neuroendocrine tumor identified in the liver that is technically resectable, that is, you can take a look at the imaging and see a means of resecting to no evidence of residual disease. Whether or not a primary has been identified, I think my approach to that patient would be to take them to surgery, explore them, resect them to no evidence of disease, and then absent data for adjuvant use, which we really don't have yet, I would say that would be the extent of treatment, and then I'd follow the patient. If that patient recurred, I think consideration of some of these other treatment strategies would be valid. But the best chance for a long-term outcome is with complete removal of all sites of disease. And if that can be done surgically, even if the primary is a tiny small bowel primary that you've not identified, you might identify it at the time of exploration to resect the liver disease, because you're going to examine all of the bowel, you're going to look for lymph nodes in the mesentery. And even if you don't, if it's a small pancreatic primary or small bowel primary, so be it. Removing all the disease in the liver, I think, will be of benefit to the patient.
Yes, and progression is the criteria. Well, like I say, when we get the registration, then we can make those kind of decisions after a very wonderful debulking procedure with intent to get residual. Then you follow it with therapy with PRRT. We don't have that luxury now. So by the debulking surgery, which may stop progression completely, then I think you're right. Absolutely, we'll have to follow with CT at the present time. I will say the gallium-68 for restaging is going to replace all of this, because it has the ability, as you saw in that 5th patient. I mean, it finds things below a centimeter. if they have receptors.
And that may redefine unknown primary.
Yes,
because
it
when
will.
you have that available, maybe that tiny lesion in the pancreas of the small bowel will be seen
Yeah.
and guide surgery.
Also, surgical
Probe.
gallium paddles for surgical resection.
Probe.
The probe.
Right, so let me comment on that for a second. Having had some experience with both FDG probes in the operating room as well as technetium probes, et cetera. The problem with using those to guide surgery intraoperatively is that with all of these agents, as you saw even in the imaging, there is background from kidneys and bladder because most of these agents are excreted in the urine. And when you're in the operating room trying to shield those organs which have a really high uptake in order to see very small things or have the probe guide you can be very difficult. So until they develop instruments that allow us to detect these agents with appropriate shielding to shield out the areas, it can be a challenge to zone in. If I, though, have a gallium type scan that we saw showing you really small lesions and it is co-registered with a low dose CT scan that I can get some anatomic coordination or confirmation or context of where the gallium is picking it up, I'll be pretty good at finding that area that lit up and then removing it, and you could even then, measure it once the tissue is outside of the body where all that background is to confirm you got out what you thought you were going to get out.
Yes.
But using those probes, and I've tried it, can be difficult with background.
Just one comment, Steve. We use the intraoperative probe for breast cancer, sentinel lymph node identification, as well as actually parathyroid adenoma. The trick on that to get rid of the background activity is to inject and do the surgery probably even as late as 5 days after injection. Several days after injection, everything is clear. And for probe, as you know, it's extremely sensitive.
Yeah.
You don't need much activity. So ask your nuclear medicine colleagues to, if you want to try that, to inject it much earlier, maybe on Mondays, and then you do your surgery on Friday.
You're talking indium-111?
Any agents, radioactive materials.
Just so that has a durability,
because
half-life.
it clears significantly from
Amount.
the back, and that's a major problem. We were facing this at MD Anderson as well when we were using intraoperative probes. So the trick is, first of all, injection a smaller amount than the diagnostic dose, and also wait probably 4 or 5 days, and you're going to have much better.
Here's a question I think Dr. Gerstein can answer. When a tumor is tested to see which treatment might work best for you, how helpful are the results? And I'm thinking maybe of like these markers for some of the VEGF or the predictors that Matthew Kolke talked about. Doing a kind of a genetic testing to see if.
Right, I'm not aware of anything that's being used right now.
Yeah, you can't. No, I'm not either.
I
was thinking of
there's an array that we can use for breast cancer. There's an array we can use for colorectal cancer and lung cancer as well. In metastatic disease for salvage therapy in patients, we can actually do chemosensitivity testing or chemoresistance testing, which has plus-minus results in when you take it to the clinical setting. But for carcinoid cancers, I'm not aware of anything that's being used.
No, not yet. I don't think. Here's a question I might be able to help. What is the difference between sandostatin or octreotide and somatulin, which is lanreotide? Is one better than the other? So we did these studies a long time ago, and it was done with displacement using membrane. And it's one of those things, you turn them both upside down, they look the same, period. I think maybe in the long run, the lanreotide isn't quite as good with its affinity, its ability to bind to the receptor, as well as octreotide. And the modification of the octreotide that we're all talking about here, Dr. Delpassand is talking about octreotate, which is a modification of octreotide. And the one we talk about is the DOTA-TOC, where they take an amino acid, they take the phenylalanine 1-mer off and put tyrosine there. I believe that they're both, if you think about them, they're somatostatin lookalikes. But there is no difference. The advantage of one over the other is that the somatulin or lanreotide depot gives you a square wave when you inject it. It goes up and it stays at the same level, and there may be a little bit of stacking as you take the shots when we get it. So it's as good as the subcutaneous pump that the infusion of octreotide using an insulin infusion system. But there is no short-acting, so they got rid of the short-acting lanreotide in Europe many years ago. So both of them use the short-acting octreotide to load or to handle for rescue. Last part of the question is, how effective is interferon as a treatment?
You comment on that.
Okay. Well, it's had a couple of lives, and Dr. Oberg, and most of you are well read on this, Dr. Oberg has kept it alive for almost 25 years. And at one time when Mayo looked at it, they said, well, it's the form of interferon, alpha interferon, that the more crude stuff that they were using in Europe imparted a little bit more effectiveness. And in fact, I think there's a SWOG or an ECOG study going on now that has Sando and interferon against Sando and bevacizumab. I think it's a comparator study. I think that's right, and I think it's a SWOG study. I think James Yao designed it. But there's a bit of downside that I can't speak to, but I'm sure Dr. Gerstein can in regarding the effects of interferon.
Well, interferon is not a non-toxic drug. It's very difficult to take. Most patients cannot take the full dose. Most patients will not complete a course on the interferon.
Really? Yeah. That's been, we had a medullary thyroid that only was able to take it for a couple, but we had nothing.
Yeah.
So, if the tumor does not secrete, is not bioactive or has a biomarker that is active, what is the best way to monitor growth and spread? I say if the gold standard at this point is still CT-MR, and you have to live by the standard. I mean, that may, whether it's the least sensitive, but it is the gold standard. That's how you mark progression. I believe using RECIST criteria 1.1 is that.
Yeah, but the question. Another question is, how frequent are you monitoring these patients?
Yeah. So I think now it's all a matter, and I'd like to hear the other clinics talk. But I think once you have done the surgery, we routinely, Dr. Howe, we see together every 6 months for at least 2 years, and with a CT scan, and then decide how, if we can extend that to 9 months or a year. But I think 6 months, at least initially, we're pretty, we're with some, and maybe even 4. I want to hear Dr. Gerstein.
Well, what I do is I will adjust that depending on the differentiation of the tumor.
Yeah.
So a more well-differentiated tumor, a slower growing tumor, a low proliferative index, I can see going to the 6 months. Yeah.
Otherwise, you do.
Otherwise, I'm doing 3 to 4 months in the beginning.
Yeah.
In the beginning, in the more aggressive tumors, just to be sure. And then once I'm convinced, even in the more rapidly more aggressive tumors, if I'm convinced that it's not, if it's going to come back, and the more aggressive tumors are going to come back earlier than later.
So that's true.
So then I'll spread it out.
And the markers can help a little bit. Just, I think they are predictive. I think the pancreastatin is, to me, it says the ground is shaking, and if it's doubling and it's abnormal, 300 and it goes to 600, it's gonna show just, and that would change the frequency of the CT. Go ahead.
Just a quick comment. Also, remember the RECIST criteria are predominantly anatomic criteria looking at size of the tumor, and one of the issues that I've had is that they were initially designed for chemotherapeutic trials, which looked at shrinkage of tumors, which was effective with systemic chemotherapy. With some of the newer techniques we have, which particularly with, for example, radiation spheres, and I think with these newer PRRT, we're inducing apoptosis, and we're not necessarily seeing shrinkage. We're seeing programmed cell death. So we're measuring it in different ways. For example, we're looking at stability of a lesion and lack of perfusion and other functional characteristics. So we're looking more in depth at the CT, looking at the perfusion characteristics. If we can follow something by PET CT to follow the activity, we're doing that. And I think that we're going to see evolve more sophisticated ways of assessing patients' response to therapy than just size criteria.
Comment.
I agree. Actually, we are trying to add a P in front of resist, make it persist criteria, because it's a functional index. I mean, it's very important. The problem is that at this point, FDA is not still up to the bar. I mean, they are still insisting on resist, and that is one of the problems in evaluation, especially of neuroendocrine tumor patients, because these are typically slow growing, and if you want to evaluate response to therapy only by more than 25% shrinkage, you don't get it all the time. But if you say that, okay, yes, it has not shrunk in 25%, but the PET scan was this positive and now it's this negative, I mean, this should have a value in here.
I'm not as concerned about the response, quote unquote, criteria for RESIST, because it's a 30% decrease, counts as a response, and you can certainly score for stable disease as long as you have a proper control, et cetera. What concerns me most about RESIST is what they consider progressive disease, because many folks fall off of clinical trials or off of a therapy as being declared ineffective because of a 20%, 21% increase in the size of their tumors or a single new site of disease. And that, I think, is setting the bar too high for what could be effective therapies in terms of controlling disease in a patient, improving time to progression, et cetera. And we often take patients off of or throw therapies away for what is very little impact progression on a patient's outcome. And so my bigger concern with RESIST is where the bar is set for declaring someone or some therapy has failed. A single 1 centimeter lesion pops up in the lung in a patient who had very bulky disease in their liver that had a response. If a patient has a 35% shrinkage of their disease in their liver, but a single lesion pops up in the lung that is bona fide recurrence, that's progressive disease as far as RESIST criteria is concerned, even though the bulk of disease in that patient has responded to therapy.
So here's, let me just say, here's the take home from what all my colleagues up here just said. The take home is stable disease ain't bad, especially in these very slow growing tumors. Okay, and you got to remember that. And one of the things, our goal as oncologists, as treating our patients, is our goal A is cure, obviously. We'd love to cure everybody. But goal 1A is longevity, is keeping you guys alive and turning cancer, any cancer, including carcinoids, into a chronic disease. And a chronic disease you can live with for 10, 20, 30 years. And just think about all the other diseases in medicine outside of cancer. Heart disease, diabetes, we can't cure that. Can't cure any of those, okay? But we keep our patients
The way
alive.
I like to think about it, and I think it's partly, putting the positive outlook on it, is although, yes, goal 1 is cure, but goal 1A++ in my mind is, God forbid, but we all have to go sometime, is that you may die with your disease, but you'll die at 85 skydiving on your 85th birthday. So everybody ultimately, until we've figured out a cure for our own mortality, is going to die of something. We just don't want it to be that cancer that you have. And if it's skydiving or racing NASCAR, that's a good thing. That to me is the one AA+.
Excellent. I think this question is apropos because it might clarify the typical atypical pulmonary carcinoid. Not symptomatic, but diagnosed with typical lung carcinoid by needle biopsy. What is the next step? Age happens to be 79. Comment, I do not want lower lobectomy, which is advised. Blood work's never been tested. Let me say just what Dr. Gerstein did. He does not consider a typical carcinoid as benign. And the ENETS people, the ENETS people in Europe, the two people that spoke on the lung said there is no such thing as a benign carcinoid in the lung. That said, the difference between a typical and atypical may only be a slight bit of invasion. They're going to both be described as well differentiated. Don't fool yourself. They're going to look like typical cells, and it's where if they go through or there's a lymph node or they miss a lymph node, and now you're in a different zone because the atypicals do behave badly if left unattended. Extirpation was the word that Dr. Lubati used, and that's a great word. You extirpate them. And you can do it with the magic of the thoracic surgeons and anesthesia, and I think it's worth doing. I appreciate comments on.
Some of the things that we've done is we've helped the thoracic surgeons for smaller lesions by putting fiducials or putting
Yes.
markers in a wire, a hook wire that comes back out through the pleura. So when the surgeon goes in, just dissects down on that and is able to take it out. And that's for certain types of lesions, but that can be effective.
Yeah, and the other thing is, if this was amenable to a needle biopsy, it might be a peripheral lesion. Even a VATS procedure might be able to
Yes.
handle that.
Or percutaneous radiofrequency ablation.
Yeah.
Right.
Yes. Leanne, can more specific nutrition, it says can more specific nutrition recommendations, foods to avoid, foods to consume, especially vegetarian, vegan, they're asking for little.
Foods to consume are still foods high in protein, especially with people that are vegan and vegetarian, where we might not be getting, because of intolerances in the GI tract and not being able to tolerate insoluble fibers, where we really depend in that area on dried beans and mixed proteins, would be a real concern. So, and I may have spoken to the person that asked this question actually, but I do recommend those that can, and even with their beliefs, can consume egg whites, or whole eggs are fine, but egg whites and fish to be very beneficial. They're easy to digest, and eggs are your highest biological source of protein, so I do use it in the diet. If your cardiac risks are very high, you may want to not use the yolk every day in particular. So I do consider it a very important food. Fish is a very important food. It's very easy in comparison to many of our other protein sources to digest, and it has some benefits, especially our cold water fish, salmon, and such for the vitamin E also in those. Vitamin D sources are very important. Dairy in many of the patients are not easy to consume if they have a lactose intolerance, so I do advise either using the lactate tablets so that you have an enzyme on board so you can get your dairy products in. Are very beneficial because they have both the protein and the carbohydrates that we do need. Again, you're at risk for other diseases. So just because you have this, and especially if you're chronic and we move it into the chronic, your risk for other problems are still there. So we still want to be looking at things that will reduce your risk for heart disease and also diabetes. The foods to avoid if you're having diarrhea, I think fruit juices really complicate treatment and do increase your diarrhea. I'd rather you use fruit sources from the fruits themselves and back off the fruit juices just because the sugar content usually increases your diarrhea. If the vitamin D is a problem, I have told this to a few people, there's a couple of tricks in the vitamin D arena. One of them is if you consume mushrooms, that you can take mushrooms after you have purchased them and put them in your windowsill, and they actually can increase the vitamin D content. It's estimated at 10,000 units. So you actually can increase your vitamin D on a mushroom. So there's some things like that in those areas that we can consume. We definitely have a problem with the fat-soluble vitamins and sources of these in the diet because of diarrhea in many of the patients that I see. So, and also I'm a believer in using sun therapy for vitamin D, and in some patients even sunbeds, although you do have the risk for cancer. And as a cancer preventive advocate, I don't want your face exposed, and I want you to do it early in the morning and late in the afternoon so that you don't get as much risk for for sun cancers and skin cancers. But I do think that those are things that really need to be taken into consideration. Increase fruits and vegetables when you can. I do believe most of my patients have to have cooked forms and very soft foods so that it may take out some of the raw fruits and vegetables that people are interested in consuming. But so you may have to change your belief in that a little bit and do the cooked. Of course, we know that cooked foods with a little bit of fat in them actually increase the fat-soluble vitamin absorption. So.
Here's also, how can you prevent protein loss? What proteins are better than others? You alluded to that question. But the first one is a little harder. How do you prevent protein loss?
After surgeries, it's anytime you're losing weight, you're going to lose some protein, so it is a big problem. One of the biggest things is to make sure that you get enough calories so that your body is not using protein and having to break down protein from your muscles to provide it as an energy source. It's a very expensive energy source, especially when it's coming from your body. So increasing your carbohydrates are very important in maintaining muscle mass, using resistance and exercise and resistance training. We're using bands and trying to get people to do, and I think most of us, especially, I'm looking at the surgeon here because this is where we usually see a lot of our loss, in trying to keep muscle mass is to use the muscle, because if you gain your weight back after surgeries, it's going to go to your abdomen. So.
I'd like to add, if I could, one thing that I tell. Thank you. I'm sorry. That I've noticed, and I'd like to hear the experience of our other colleagues. But it's very, very interesting. And when you're looking at a patient, or you come in with 50% liver tumor burden or 30% liver tumor burden, I'll often say, gee, you have only 30% liver tumor burden. And the next thing I say is, you need to remember that your liver will function, and that was alluded to. Your liver will function normally, I guarantee, until about 20% is left only. This is not cirrhotic, otherwise cirrhotic or an alcoholic, hepatic liver. This is a liver that we have 100% liver, and it is taken up with a tumor, but it does not compromise your function. And we heard about total bilirubin. You start to change the ante if there's obstruction and what have you. But
yeah. So what Dr. Odorizio is talking about is the liver as an organ has a function, and all the hepatic cells contribute to that function. When you have a tumor that's occupying a space on the liver, whether that space be 10%, 20%, 40%, or up to 75% of the liver, the remaining percentage of liver that's unaffected by the tumor is still functioning properly. And the typical case is you can function, you can have enough reserve function of the liver if you have as little as 20% of your liver still functioning normally. That's different in a patient that has end-stage hepatitis or cirrhosis, where the hepatic cells are diffusely affected. It's affecting 100% of your hepatic cells, and they're not functioning properly. That's a completely different situation. So I tell my patients the exact same thing.
And that's the good news, bad news about a liver transplant, because you almost never make the MELD score for a liver transplant eligibility, because your enzymes and your total bilirubin, it doesn't change. Go
In
ahead.
the U.S. now, you get extra points for cancer, and
Okay.
so it moves you up on the
Okay.
list just by virtue of the diagnosis.
Very good.
But the key thing with transplant, and why we hold it way in reserve, especially for neuroendocrine tumors, is that you are really trading one disease for another, because after a liver transplant, you are now battling against your immune system with medications to keep that in check, and we know that lifespan is limited just by virtue of the liver transplant. And so when you have a slow-growing tumor type that you can live a completely normal life, again, getting back to that chronic disease issue, for many, many years, you have to be very circumspect about doing a therapy that you know is going to be life-limiting even in and of itself.
Yes. And a question for Dr. Gerstein, and then I think we're going to have to stop. Afinitor, benefits, purpose, side effects, in one
Well,
paragraph.
Afinitor is one of those new drugs that Dr. Odorisio mentioned before, mTOR inhibitors, and it is used in advanced cases of carcinoid cancer. It clearly has activity in carcinoid. It's just FDA approved for PNETs, pancreatic neuroendocrine tumors, but I have used it also in midgut tumors as well. It has obviously it has a measurable response rate, or it wouldn't have been approved. It's not the miracle drug. It has significant side effects. It's not an easy drug to take. We have a couple of patients that have had it. It's one of those, it's in our armamentarium. What can I say? It's not one of my favorite drugs.
I think we covered all of the questions. I think
Dr. Odorisio, if I may just
Yes,
make
please,
one
please.
comment. There has been a lot of questions, informally during the lunchtime and break times about PRRT. My clinical coordinator, Mrs. Susan Cork, is in here. She has prepared nice handouts describing majority of the questions that all our patients they have in beautiful handouts. So please feel free to get it from her, and she is sitting back there. And that should answer all your questions that you have. Also, there are contact information that you can ask. If you have any other questions, you can contact her, and she can answer your questions.
Okay, well, how about a hand for our panel?
Yes.
Thank you all very much. I think we can